Welcome, everybody. I would like to welcome everyone to the SACME Community of Practice for Using Social Learning Principle in our field. My name is Mila Kostic, and I am one of the facilitators today of this webinar that we have envisioned really as a discussion about what motivates physicians and other clinicians to learn and change their practice with a focus on social aspects of learning and practice. Before I turn this on to my colleagues, let me take a minute just to talk about some technical issues because this is still a fairly novel technology for us in the society in education. So try to avoid using cellular and cordless phones and use phone line for audio connection rather than through the computer. You will have a better audio. And when you do that, please include your audio pin as you are signing on. Also, important to use your handset or headset instead of speakerphone because of the background noise. We do ask you to turn off your call waiting and to please avoid putting your phone on hold during the teleconference. And also, you don't have to worry about muting yourself and unmuting because we will be doing that for you. If you are having sound quality issues, please hang up and dial again. That's helpful. In terms of procedures during the call, I would like to ask you to engage in the discussion, and there are two ways to do that. In the top left, under the orange arrow, you will see a hand. You can raise your hand when the time comes for discussion, and we will unmute your microphone and allow you. I will call on you and allow you to speak. The other way, and that's really a preferred way, we ask you to introduce yourself, and if you're addressing anybody in particular, you can let us know who you're addressing the question to or a comment, or if it's just general, please do that. Another way to engage would be to put a question, type in a question in the question section, and we will again either call on you or answer the question, one of us. I believe this is all I had to say, other than to say that we have a formal, semi-formal presentation for about 20-25 minutes, and then would really like to devote most of the time to an open discussion. I would like to now introduce our President, Dr. Sachdeva, who would like to introduce this initiative for the society and welcome everybody. Sach, please go ahead.
Thank you so much, Mila. I hope everyone can hear me. This is really a wonderful occasion. I think it's the launch of what I think will be a very exciting and a very novel concept for our society. And just to give you a little bit of background, I'm not going to take too much time. This really got started about 10 to 11 months ago. Mila had arranged a virtual journal club on the same subject, and as you know, Mila has been the architect of that program, and that program has been very successful. And John Parboosingh was the speaker, and he talked about communities of practice. I had the opportunity to be on that journal club, and I was very impressed by the directions that were articulated and John's presentation. So I spoke with John one-on-one, and we convened subsequent to that a small group that includes John, Mila, and Betsy Williams, the chair of our scholarship committee, to undertake this effort as a new program for the society. Since that time, every 6 to 8 weeks, we have had conference calls between the four of us trying to envision where this might go. And that effort has culminated in this first ever webinar on the subject. And we are going to embrace this as a major program of the society. And I brought this up even at the meeting of the Academy of Fellows of SACME a couple of weeks ago. We met on the phone, and there was a great deal of enthusiasm for this. So, without further ado, I will turn it over to John. I do want to also thank Katie Keel from Bostrom for her help with setting this up, and we really appreciate your being part of this endeavor and look forward to a very exciting conversation. So, thank you so much, and over to you, John.
Thank you, Sach. And hello, everybody, and welcome to our webinar today. Over the past year, just as Sach has just mentioned, we have met, as Sach said, every 4 to 6 weeks, and we discussed the impact of social interaction at work on physician learning and practice improvement. We found that ideas from social learning have the potential to enhance CME and CPD. For instance, we learned that building relationships between physicians as they discuss practice experiences facilitate behavior change as much as the traditional focus of CME on providing high-quality evidence-based content. At the same time, recent publications on physician preferences in CME remind us that learning while caring for patients is perceived by physicians to contribute more to a physician's professional development than many other types of CME. So we feel it's time to explore how we can use social learning thinking to weave CME into the fabric of clinical practice. We believe the best way of addressing this ambitious task, and it is a very ambitious task, is to tap into your creative talents by inviting you to join a community of practice to explore this topic. For today's presentation, we have selected a few CME topics that are seen differently when viewed through a social learning lens. They will be explored further by our community in coming months. But today's discussion is really to whet your appetite and encourage you to join the community and express your views, recall your stories, and exchange literature on the impact of social learning and CME. But just before we get on to the meat of the webinar, I just want to say a few words about why communities of practice. Our society has created valuable networking tools in the form of the annual meeting, the intercom, or listserv and journal clubs, and more recently, a state-of-the-art textbook. What's missing in our knowledge network is a method whereby members with similar interests can exchange ideas from which projects and other SACME products might emerge. I'm reminded of a statement by Henri Kerr shown on this slide. Henri said, "The biggest information repository in our organization sits in the heads of its members, and the largest communication network is the web of conversations that binds them." So communities of practice have been shown to be a good way of fostering conversations. Our community, using social learning principles in CME, that is today's topic, is likely the first assigned COP in the society. We hope to encourage more COPs, giving members the opportunity to participate in the society's conversations. Feel free to contact myself or Mila for help in starting another community of practice. So let's get back to today's topic. My first topic I selected to present today through a social learning lens is the issue of learner engagement. It's the centerpiece in social learning, as shown in the quote on this slide by Bharat Anand, a founding member of the Harvard Business School program called HBX. My research group reported on this issue some years ago and suggested that changes that could be adopted by CME to enhance physician engagement in the learning process. I will touch on 3 of these suggestions from this research group, which I had the privilege of being a member of. First idea was changing the learning venue from a classroom to a lounge style, where participants meet each other eye to eye. I have found this to be extremely effective in generating physician interest in the learning process. Yes, we know that in many conferences now we are at round tables, but round tables still face the center of the room where the sage is still on the stage. And we really want to focus on eye to eye between individual participants. Second suggestion we made was when it comes to starting a CME conference, we frequently start by identifying the best practice that we want everybody to adopt. Nowadays, in contrast to this, many organizations now start a discussion with the individual telling a practice experience, a story. And these stories have been shown to be more likely to promote learner engagement than the case report typically recalled at grand rounds and CME programs. So our second suggestion is encouraging physicians to start to exchange stories about their practice experiences. My third suggestion for exploration by our community is the issue of physician empowerment. It's central to social learning. CME today encourages physicians to adopt an evidence-based best practice. That's the goal of the CME programs. In contrast, most continuous improvement strategies in companies, such as Toyota and Cisco, for instance, empower their workers to first talk about current practices, then pull in evidence-based best practice into the discussion as they co-create a vision of a better practice that fits local culture and context. When we were discussing this issue in our research group some years ago, I recall a physician member commented, as shown on this slide. He said, "I don't know any physicians who go to CME to exercise their creative talents." Recent reports on physicians' preferences in CME and CPD tell us that physicians are ready to actively contribute in this way to continuous practice improvement. So let's move to my second example of how learning thinking can impact CME. And this relates to the issue of constructive learning that actually changes practice as opposed to impacting on physician knowledge. I noted this statement by Ayelet Cooper back in 2009. Ayelet is from the Wilson Center in Toronto, which is shown on this slide. It reminds us that some types of learning emerges from interactions and conversations between people. But not all conversations are generative, that is, lead to action. Nick Abbey, when he was a fellow at Johns Hopkins some years ago, wrote on the subject of structured dialogue. And I quote on this slide. Nick tells us that conversations structured as a dialogue have earned the reputation as a method of learning, a pedagogy with strategic capabilities. I draw your attention to the quote from Nick at the end of this slide. Yes, dialogue is strategic. It leads to a how can we do this better type of conversation. While debate, for instance, often leads to a we can not adopt this new practice because type of conversation, a negative conversation. I look forward to hearing the opinions and experiences of members of our COP as we explore the literature on these topics in coming months. Okay, Mila, I'm passing the mic over to you.
Thank you, John. So in continuing what John started, I wanted to reflect us back onto the this idea that learning in communities of practice really represents realignment of competence and experience that practitioners, as participants of the community, bring to the plate. So, social learning spaces is a construct that Etienne Wenger came up with. I believe we provided references, and it would be great if you could look at his 4 examples, I believe from 1999. But when he talks about creating social learning spaces, he equates that to social containers that really enable genuine interactions among participants and practitioners who can bring to the learning table both their experience of practice as well as their experience of themselves in practice. When you think of that, it's a very different construct than a construct of a learning environment in a classroom, for example, or even books and websites and any instructor-based resources that tend to be closed and prescriptive in nature. So the communities of practice, when they are constructed and function well, Wenger says, are really a good example of this social learning space, because the learning space of community is built through a history of learning together over time. He also talks about other potential types of these social learning spaces. Even a good conversation, for example, or well-designed workshop could be an interesting case conference, could be shorter and more concise, but still meaningful social learning spaces. So there are several constructs and ideas that he goes deeper into when describing social learning spaces. Others have called this type of learning consequential learning, but it is about meaningful engagement of participants in the learning experience. These types of newer learning activities have been criticized that they lack the rigor of evidence-based. So his response to that is that really it's very important to understand that producing knowledge that is livable in the experience of practice requires discipline of inquiry that takes practice as the place of knowledge and the person as a vehicle of knowledgeability, a term that he coined. So knowing is important as knowing in practice and knowing as identity in this rigor of inquiry. When he talks about knowing as practice, knowledge is not separate from people or process, but is really part of mutual engagement through which participants refine and explain their experience of practice. And he goes on to say that knowledge is really part of engagement in the world for us as individuals because of this focus on practice. And as a lived experience, it is very personal. It includes physical, emotional aspects as well as cognitive. And knowledgeability is a form of identity then anchored in practice. When we add to that the complexity of the current constantly changing world, he continues to develop this idea of the tension, learning being a tension between the competence as a socially defined aspect and our own experience and identity that brings meaning to learning. And we function these days in complex learning environments, and something he refers to later on as learning in the landscapes of practice. So that learning becomes a trajectory of practice of learning, and forming an identity of an individual in that conceptual framework is really learning across the landscapes of learning. And then, of course, these landscapes become about the networks that we all engage in, which, it's about our training, about clients, about research disciplines, one or more than one, about regulatory body, professional bodies, and so on. So this dynamic becomes quickly very complex. So the rigor of inquiry is quintessential and central to this process. And there are some, as I said, accountability of learning to the practice changes and to identity is critical. And it includes the ability to find meaning in activities and engage competently with other people involved. So it poses a question of recognizing other participants of the community as practitioners and as peers. So learning is a partnership. It is a commitment to candor and value of practice-oriented trust. It is one of the pillars of the discipline of social learning spaces. Participants recognize a practitioner in each other as they engage in negotiating mutually relevant stories of their respective experiences. So that togetherness of practice is on the pathway to forming shared experience. Engaging with knowledge as lived in practice requires a lot of trust. And that's because practice is not a scientific construct. It is messy oftentimes, it is improvised, and it certainly requires judgment. So this learning process in such an environment leads to reframing often of the stories that John talked about earlier that we may bring to the community of practice. And that happens through the commitment to openness, to trust. When this kind of engagement becomes a curriculum in itself, then the learning process has to unfold out of these interactions among participants. And then mutual engagement and negotiation really becomes a way for people to build a shared and deepened understanding of a situation at hand. So we're back to the practical issue and the practical problem that people are trying to solve that is at the core of the community of practice or other types of social learning spaces. He also talks about the fact that by giving voice to mutual experiences of practice, the interplay of diverse perspectives then often reframes that initial story we came in, and our understanding of the practice, and in doing so, also reframes oftentimes who we are, and we are back to the identity question. There are obviously many other authors who have thought through the innovation in learning in the 21st century. One of them, this is a wonderful little book, A New Culture of Learning, by John Seely Brown and Douglas Thomas, and many of you, I'm sure, have seen it. So they talk a lot about the interactions between learners and in a larger learning space. So the question of how to build a culture of learning in the systems where the only the constant is really the world of constant change, becomes more about question and inquiry, and less emphasis is placed on answers, a curriculum, or a teacher as a sage on the stage, but rather we need to think about teachers and teaching more in the reframing that and shifting it more towards the mentorship and guidance. I believe that John Seely Brown was actually credited with changing Descartes' I think, therefore I am, into I participate, therefore I am. And so I would like to leave you with this notion and turn this over and open it up for discussion. So again, the way to engage is raise your hand, and we will unmute your microphone, and you will be open. It will be open microphone for the next, mostly the remainder of the program today. Or
Thank
you
you,
can
Mila.
type in a question.
This is Katie, and there is a question up on the board. I can read it off, or a statement maybe rather. It says, diversity is one of the cornerstone of social learning and and networked learning. Therefore, I'm wondering if it's better to talk about physician-only social learning or about interprofessional social learning. And that was from Gako. I'm sorry about the mispronunciation of your name.
That's a great question. Thank you for that. So everything we're talking about today is certainly can be thought of in our current time. So interprofessional learning is the form of social learning, and it starts there for us. And we certainly want to think of it that way. It's not only about physicians, and in particular, actually, when they talk about learners as members of the communities and social learning constructs, it is emphasized that the peers are thought of as people who leave their badges and their doctorate degrees or at the entrance and agree to be peers because of the commonality of the practice they come from. So, John, would you like to add something?
No, that's nicely said, Mila. I would just add to that by saying it's not just other professionals. We've got to think of the workplace. They're all functioning there as agents, rather like in a complex adaptive system. So there are administrators there. In some of the communities of practice that I have worked with in clinics, the receptionist has been a very active part of the discussions.
That's for sure, yeah. I don't see any hands raised. And I know I see we don't have a lot of shy people on the webinar, and would again love to invite everybody to contribute, to think aloud, to talk about their experiences. So many of us have engaged successfully or less successfully, or are thinking about engaging some of these concepts within our practice and in designing these learning spaces, social learning spaces. So if you'd like to talk about that, please do so. I see I'll have to call on somebody.
We do have a hand raised here.
Okay,
and I will unmute the line.
Great, thank you.
You're unmuted.
Who is that?
Vieko?
Oh, Vieko.
Okay. Sorry, this is Vieko. I have a question. What's your opinion about technology that plays in social learning? And if you're talking about community of practice, is it possible in CME environment to expect that we'll have online community of practice?
Of course. I think technology is a very important element of it. And in fact, John is going to talk about this more. We are thinking of engaging technology and websites that we will need for this community to anchor it. So, John, why don't you say more?
Yes, it's interesting because when I first started to relate to some of the companies that have more very elaborate continuous improvement strategies in order to stay competitive, technology is right front and center. The only way we can create an ongoing social learning space for a group of busy clinicians, for instance, frontline operators, is for this to be virtual, because they cannot really attend face-to-face meetings constantly. And one of the interesting points that Bharat Anand makes in his book called The Content Trap is how to make virtual spaces more conducive to worker empowerment and actually enhance physician engagement. And he's developed a number of digital designs to help that to take place. So technology is absolutely essential for this to take place. The second point that you made is that I think, you know, we've got to think of everybody we communicate with now not as individuals, but within a network. And I think the best way for this to happen is really for you to see an individual, just like a doctor talking to a patient. It has to see that what's the network around this patient, who influences this patient, who is important to this patient, what are the barriers that makes the communication successful. So I think we should always think of individuals within communities. Mm-hmm. Is that helpful, Mila? I'm not sure.
I think so, yeah. Diego?
Yeah, thank you very much. Maybe just kind of maybe sub question is, so I'm guessing if we're talking about community of practice or social learning, that should be somehow mentored or guided, and I guess that's a big change. At least so far, when I was ever talking about collaborative learning with colleagues, usually when it come to the discussion, who will moderate that discussion? Yeah, that's where everything will go south. So yeah, what's your suggestion how to address that? Or
that's a wonderful question, and I'm very pleased that you brought it up, because many of the reports that I have read on communities of practice, the thing that's missing is expert facilitation. And the facilitator of a community of practice really has three roles. The first role is how to build community, how to build relationships between individuals, because that determines the success of the community. The second one is to curate, and that is make sure that you are acting as a librarian that brings the literature at the right time, when the discussion needs it, as opposed to just creating a library for people to access. And the third role is how to facilitate a discussion without taking it over. And that requires a lot of encouragement. And in fact, some time ago, I developed an online course to teach people how to do this.
Thank you, John, and thank you, Diego. We have another question. So this question is for John, and it says, could you please elaborate on your comments about the place of debate and discussion in educational activities? You mentioned debate often builds upon a negative premise. However, if you have two individuals who are able to articulate their views on a topic, couldn't that lend itself to sound learning through hearty and balanced discussion? Does it always necessarily put a negative frame on the conversation? And this question comes from, I can't really see, maybe Katie, you can help.
Sure, that's from Jenny Jacob.
Oh, Jenny likes to put questions in.
Hi, Jenny, it's John speaking. Yes, that's a very good point. I'm not saying we should throw the baby out with the bathwater. Not at all. There are times when the right method of communication is by debate. But quite often a debate, and I'm thinking of two sources of literature. One by Daniel Kinahan, who has done his research in behavioral research amongst individuals. And the second source of literature is from Yuri Hassan and others who are doing functional MRI on scans on the brains of people as they undertake these different types of communications. There's a wonderful TED talk on this by Yuri Hassan, which is absolutely fascinating, and I would encourage you to mention. But the point is that if you want to involve more people in the discussion and allow them to engage in the process of education, which leads to the emotional reactions and other areas which leads to efficacy and a commitment to change, then the literature suggests that the way to start is through dialogue as opposed to debate.
Mm-hmm. Thank you, John. We have another discussant. We have Linda Lupi, and I have unmuted you. Linda, go ahead with a question or comment. Linda?
I think we have a couple other questions in the queue here. Do you mind if I run through them?
Okay,
this is Katie.
go ahead.
Okay, our question is from Christine Flores, and it reads, most of the situations you've described are ongoing experiences. Are there any applications of these theories to one-time events or week-long conferences?
I think I touched on it. Yes, a good workshop, a really well-facilitated workshop, for example, could be considered a social learning space and could be something that can be built on. But again, you know, it really it's cornered in these requisites of engagement, of peers with questions of shared practice. So as long as these some of these postulates of behaving and that I established this kind of learning that is managed through the community, the participants engaging in building or co-producing knowledge rather than having one-directional teaching. You know, those I think that can be established certainly.
Just to add to that, Mila, I think that what's important is who has been invited to the event, and if there's already social capital developed within the group. So, say it's a clinic that they all know each other, and there's some very important social capital built there already. You can do this in a single morning or 1.5 hour session. But the important thing, it's also ongoing, so that when this group meets again informally at the water cooler or at lunch, the discussion continues. And I remember when I was at the Royal College having formal committee meetings, I always said, I wish I could be in the taxi going to the airport after the meeting, because that's when most of the discussion really took place. And so I think the important thing is the social capital of the group you're talking to. Dr. Margolis in Montevideo in Uruguay, he's developing social network software that he can pull people, invite people to online conferences and face-to-face conferences who know each other and have a similar practice, so that by the time they come to the event, the social capital is already built.
And it is more, like you said, more and more about pulling rather than pushing content,
right.
and enabling that. So we have Michael Fordis. I have unmuted you, Michael. Please go ahead.
Thank you, Mila. And first of all, let me say how terrific this is, and I'm very excited about this initiative. In terms of the community, you've spoken about how certainly there's physicians, but there could be staff members and so forth. Would you say a little bit about the role of patients? There'd be a different social capital that would be involved in that. Have you had communities of practice where patients are engaged over some length of time rather than on particular occasions? And what are the strategies for meaningful engagement in welcoming them into those discussions, because there's hierarchies that could interfere with that? Thank you.
That's a great question. Thank you, Michael. So patients, involving patients in learning, engaged in learning together with clinicians as part of the interprofessional education has been something that we have talked about and dreamed about for a long time. And as you said, it's really the question of the meaningful and how is it done well. What we all know is that patients have really been used as objects in education for a long time, either as cases or something else, but have rarely had a meaningful role as equal participants in. And you know, when you talk about a patient, I've seen this done pretty well in oncology at Penn. So there are communities of learners where patients are really educating clinicians around the areas of what is that lived-in experience of my disease that became from, say, breast cancer survivors will talk about the chronic disease that they live in now with, and so what would be helpful for them to have known at the time of interventions and so on. And so there's a way to do it well, and I think that we just need to think more about that and embrace it as a concept, because at least where I live, I don't see that embraced by physicians in particular overwhelmingly as even a possibility. John?
No, I would entirely agree. I don't have experience of actually bringing patients in, but I don't think that wouldn't be the job of a facilitator. I think if you had a group of physicians and other members of a clinic meeting once a month, and I remember joining a group like this when I visited in Montevideo, where there's a group of developmental pediatric clinic that did this once a month. The person who started the monthly meeting, by exchanging a clinical experience, was invited to bring the patient that they were talking about with them, and this certainly enriched the conversation, because the discussion was between the clinician and the patient, and everybody around was listening. And quite often, when I heard one patient, the clinician said, "When you told me this is what I was thinking about." So I think it's up to the clinic, once you've got a social learning space going, and they're meeting regularly, and there's high social capital between them, and everybody knows that someone is going to come up with a case. It could be up to the group to actually invite a patient to come. I think that would be the way to bring it in.
That's very, very important element. So I'm going to go back now to Linda Lupi, who sounds like is really Moss. Moss, go ahead. I unmuted you.
Oh, okay. Thank you. I appreciate this opportunity. I wanted to go back to an earlier question about the social capital and shift and ask the question, what can you tell us about how you build in this same space the intellectual and experiential capital, so that the lessons really are accumulated and the capital is developed? And as a second part of that, is there a way to move it from one social learning space to another social learning space?
Oh, wonderful question, Miles, because I've actually been involved in this. And going back to the issue of the virtual, use of technology, this is where the website comes in. It's absolutely vital. The research group that I had privilege of being a member of, and in fact, Mary Turco is also a member, and I think Mary has registered for the program today. She might be able to speak to this. We developed a website. It's a free website. It's under PB Works. It's a California company that gives people like myself free access to build websites. I actually have 10 websites with them, and everything is recorded. And the full text papers are actually built into the comments on the pages. And right up to last night, I was going back and looking at this, and we build the criteria. And I was able, for instance, to get that comment from the doctor who said, I don't know of any physician who goes to CME to exercise his creative talents. I picked that up from our website. So I think you have to have a concrete way of building this. And it's not just a library, which I call a digital junkyard. It's a website that the literature is built in as the conversation develops. And we had at this research project, we had monthly WebEx meetings, which, thanks to Mary, we got this free and gratis from her department in New Hampshire. So I think the answer to your question is, as the conversation develops, it has to be recorded, so we have a history of it. You asked about moving it from one website to another community. And
Okay.
in fact, I'm doing a little bit of this just now because I have started an own little private website for this new community of practice. And a lot of the things that I've been able to lift from the old research group and to put into this, but this is not the conversations, this is just the literature and things like that. The conversation stays with the community.
Okay. So it brings me back to some of the other, I won't say lectures, but initiatives that we've had as a society. For example, if you recall, John's and several other presentations at the Journal Club had dealt with some of these concepts and examples of social learning. We also had a session at, I believe, 2015 fall meeting that was learning in the workplace. It was a panel I moderated, and we had many sessions that were very relevant to this, and talked about activities and initiatives that included thinking through the social learning aspects of CME CPD at the World Congress. And one of the keynotes, I think the last one, left us with learning is in the doing. I'll never forget that. So this is not a beginning, I think, for us. It's a continuation, and hopefully something that we will be able to mature and more of us take part in. I have unmuted Janine. Janine, I understand you'd like to contribute a comment. Please go ahead.
Yeah, thank you, Mila, and thank you also for putting this together. The preparation and references were great, so thank you to the team. And I'm actually myself a big believer in the community of practices, and I think actually we're modeling with this webinar how we can construct knowledge together. So thank you also to all who are contributing. So my comment is, I am wondering if we could look at it, the effectiveness of the community of practice and social aspect of learning in the context of what we know about self-determination theory, which, by the way, was developed at the University of Rochester, where I'm from, and it's has grown into a big international movement. But what we know about self-determination theory are three pillars, essentially. What motivates people is, number one, a sense of competence, autonomy, and that connectedness, which is that community of practice. So if we look at our community of practice, certainly as we build knowledge together and construct knowledge or discuss it, we help develop competence. Typically, community of practice are volunteer enrollment, like we're doing today. So that sense of autonomy, of being part of a community of practice, and that feeling of connecting. So what comes first? So I wonder if the sense of effectiveness of the community of practice is how it motivates learner on those three aspects: competence, autonomy, and connectedness. So I wanted to link our discussion about social learning and community of practice to what we know about self-determination theory. And would welcome comments.
Thank you, Janine, for your comments. I'll just start, John, and everybody else turn it over. This is obviously a really good topic to discuss as a group. The way that Wang, as you know, and now his wife Beverly Traynor look at the competence, they really contrast competence with experience. So where competence is concerned, it's defined by a community and the practice, and then experience is the individual that brings the experience of practice, of individual practice, and of themselves as a person who functions in the world that is increasingly complex and potentially belonging to multiple practices, multiple communities, multiple networks, bridging that and that tension, and that's how they say learning really happens for an individual. For a group, and that resonated with me. So learning, as I said, is that trajectory within the practice of learning. It doesn't happen once. It doesn't happen, it's not static. It's ever changing. It is developing, and it is changing our own understanding of ourselves and our own self-efficacy in the world as we engage in learning with others. So I will just stop there. And so it's competence is defined somewhere else societally, and then what we bring to it as individuals is a qualitative response. Anybody else, John, or anyone?
I'd be happy to have other people talk, I think, Mila, if we could. So it's not
let me know if
directed
I'm looking
at
for
us.
hands, right?
Yeah. Anyone else like to talk about that? Because it's a very important topic, really.
It is. Would anyone else?
No?
Katie, if you see any hands raised, let us
I could
know.
just mention while people are raising their hands, because I'd really like to hear other people's opinion of this. But I learned a lot about this when I started to look at what companies are doing to, the old-fashioned word would be to sell their product. But in fact, it now comes under their understanding this as a form of research into neural behavior. And the marketing research is becoming very, very important for us in education, now that we have moved from giving the clinician knowledge, and we're now interested in how the individual is actually going to use that knowledge to better our health service and better our patient outcomes. So we're really no different from actually a company wanting its product to be used better. And when I first started to listen to John Seeley Brown, who was the director of research at Xerox for many years and worked in Palo Alto for some time too, with Etienne Wenger, it became very obvious to me that what needs to be done is those who have a message needs to get into the workplace and start to embed themselves within the workplace and the individuals there. And he then starts to move from the concept of competence to capabilities. And once you start to think in terms of capabilities, then autonomy is very important, because, but at the same time, you know, it's not an easy subject to discuss because there's interdependency. One of the things that Etienne Wenger always said is that when you're networked, you're relieved from having to know everything yourself. And I worked for many years with people. I used to introduce people by saying, he actually has a place in my brain because I depend on him for so much information. So I think, and of course, the connectedness is right up front now. And in our last lecture I forget who did it now, on Saturday morning at the Congress, talked about this. And there's some of the people on this call might have heard me say before that when headhunters are now looking for leaders of organizations, they're not interested in your knowledge. They're not interested, if they're looking for somebody in oil, for instance, they're not interested in how much you know about oil. And they're not interested in your background either. You know, how many degrees you have, and how many prizes you won at university, etc. They call that tombstone data. They're more interested in what you're connected with, who you're connected with. And so once again, we have to move from medical education from an individual to actually helping people to connect with each other.
What a great example of positive deviance, this codependency,
yes.
right?
Yep.
Stacy Samuels, I would love to allow you to speak and hear what you have to say, but it looks like you muted your own phone. So if you unmute, we can help you be able to be heard. Stacy, could you please unmute your phone? Okay.
She is calling in through the computer. We do have another question. Maybe, Stacy, if you want to type in your question. And then in the meantime, we have another question, another hand raised.
So we have Vieko again. Go ahead, Vieko.
Oh, thank you. So question is, successful online community of practice looks like a big cultural and technological change of the established CME CPD practice. So I'm guessing the big bottleneck here is education of educators. So what's your suggestion how to address that? Do we have, for example, a course, or do we have community of practice where we can send our faculty, or what's the best way to do?
Mila, should I take that? Yes, no, I don't think we should use 20th century approaches, conferences and courses. I think one little step at a time. And if you take each of those things, for instance, like one of the changes I suggested, the changes in the venue, that's the one. It's not easy to do, because if you're parachuted into the middle of a conference and you land up in a room that looks like a classroom, there's not an awful lot you can do about this. So I think you have to have a strategy to move in little wins. And I think that we're going to discuss this in great detail when we start a community of practice. And that may be one of the topics that you might like to bring as a first priority. And that's the heavy lifting. You're absolutely right. The rhetoric is easy. And even to find the references is easy. But how do you achieve transformational change? And I've looked at some of the companies like Xerox and Black & Decker and other companies like this that have actually achieved transformational change, because without it, they would die. And of course, I'm coming from Canada, and as you know full well, the Research in Motion company that produced the BlackBerry did not have a very sound continuous improvement strategy. And therefore the BlackBerry is on its way out. And so we have opportunities to learn from companies like Xerox and others as to how do you achieve transformational change. But I'd certainly have some ideas, and I'd be happy to communicate with you individually as to how to get started.
Oh, great, thanks.
Thank you, John, and thank you, Vieko. The question that you pose is of course an excellent one, and even thinking about it as quote unquote faculty development doesn't seem fitting in discussions that we're having, right? Because in multidirectional learning, you want to move away from that. Who is really the faculty, and how does learning happen as co-creation? So it's engaging learners as participants, as John was saying, in examples and multiple times is what gets people to transform their thinking and then their practice of learning. But it's also understanding that we all engage in these types of learnings, but they are not formalized.
But I could just add to that very quickly, Mila, by saying, if you know of a group, and there are lots of groups of physicians who would like to get together on the phone once a week or once a month or whatever, and would like to, but they need to be facilitated. They need help. And we can certainly produce a little online program that says, you know, how to communicate, how to facilitate an ongoing community of practice. These groups don't call themselves communities of practice. I don't know of a group who comes and says, oh, I'm a member of a community of practice. They're groups, and it's how they behave that's important. And I would add there are other groups that really do require the facilitation but don't have the resources. But my response to that always is that just think of the number of people who have to put together a conference or even grand rounds. I think of the number of people involved and the resources involved in that. If we could change 10% of those resources into facilitating communities of practice, that would be a great help.
We did receive the question from Stacy. Do you want me to read that off for you?
Would you please? Thank you.
Sure. It says, I was hoping you could comment more on the sense of autonomy by physicians, whether as individuals or as a group. This tends to factor our community of researchers and CPD professionals have not addressed in the past. And Janine brings up the need to incorporate theory into this future vision of communities of practice for effective learning. Thanks for any thoughts about how physicians perceive their own autonomy and our role with respect to education that takes this into account for any who may not perceive themselves or their community as highly autonomous.
John, you're a physician. Go ahead.
Okay. Well, I started this interest in this area many years ago when I was in a large hospital and several hospitals. It's going on for some generations now for me. And I would go to the doctor's lounge at 10 o'clock each morning, weekday morning, and watch the doctors there as they go in for coffee. And after they've picked up their mail from the boxes, they'd go and they sit in groups. And those groups are actually groups of doctors who you could say know each other, have similar practices, and there's a social capital already been developed there. And the group automatically starts by one person saying, gee, I had this patient last night. And the discussion goes on. And then there's a sequence here. I've seen this hundreds of times. And then someone will say, well, whenever I see this, I do such and such. Well, that's an example of positive deviance. And then someone else will say, well, I think we could do this better if we had such and such. And the discussion goes on like this. And what happens in this discussion is entirely dependent on the social capital around it. And you see people in a large cafeteria in a hospital at lunchtime. And interestingly, it's not just only physicians are friends. For instance, my background is in fetal maternal medicine. And at the lunch meeting each day, there was always somebody from imaging that came along, and they're part of our community of practice. But nobody around that table called themselves a community of practice. So I think that I developed a little survey for these people in days gone by. And one of the questions I would ask is, when you are making a decision about a patient, do you think of what your colleagues might think of this? So I think there is autonomy, but there's also a dependence and a belonging to a group, which we need to take into account in medical education. And we need to be able to, I wouldn't like to say the word exploit it, but take advantage of it in enhancing our educational processes.
Thank you, John. Stacy, I hope this was a satisfactory answer to your question, but your question is large, and many of your other questions are really the reason why we felt that this community of practice is something that we could establish as part of the society, and it was ripe for diffusion from our little 4-member group into a larger community within our society. So before we close today, because we are at an hour, and I don't see any hands raised or questions posed, I would love to just remind you all that, as we said, this is the beginning of what we hope to be a very productive group learning and working. We are trying to walk the talk, so the community of practice as a social construct is something we want to explore further and engage in such a way. The topic is social learning, and how do we infuse that, the learnings from social learning theories and practices, into our own practice of designing, evaluating, dreaming, continuing education, and continuing professional development in our individual context. And how do we raise that intellectual and practical capital within the society? So we invite you, John and I, and Betsy and Sach would invite you to join the community. The way to do that at this point is really just to email John or email me if you'd like to be a part of it. Our plan for the future is to have a call, not a webinar, but a group call scheduled towards the end of February. And if you email us saying that you would be part of this community, you will be invited to the call. The next activity planned for us would be a meeting in San Antonio at the annual SACME meeting, so that we can have a face-to-face. We feel it's important to do that. And some of the things that you can probably understand and think about based on what we discussed today will be to really talk about what are our priorities, where are the needs of our community on this topic, and how could we, build a website, or what are the repositories, how do we build a community, how do we create spaces technologically, aided spaces that could help us exchange ideas, exchange literature, practices, tips, and whatnot. So with that, I'd like to close and just let you all know that the Virtual Journal Club is relaunching this year. We have a full schedule for the year, and you will all be invited soon. But just because you chimed in today with us, you will be the first to know that March 7th at 3 o'clock in the afternoon, we have Jocelyn Lockyer beginning our new series of virtual journal clubs this year on the topic of our conventional learning theories sufficient to guide multi-site complex educational interventions. And I suspect that the topic of social learning will be certainly part of this discussion as well. John, do you have anything to add?
No, thank you for organizing this, Mila. I've thoroughly enjoyed it, and I hope we get members who would be interested in further discussions on this topic.
Well, thank you. It's a pleasure to work with John, and I hope with many of you. So thank you again for engaging and for joining on the call today.
And we thank our team, our technical team, and Katie and others who have been so helpful.
And yes, without you, we couldn't have done it.
Our pleasure.
So with this, thank you. We will close.